today I'll be presenting on a journal titled Guideline for Perioperative Care for Pancreatoduodenectomy. Enhanced Recovery After Surgery, ERAS Recommendation 2019. So an introduction for this journal. So ERAS is a multimodal pathway that can be implemented towards the patient. It started pre-operatively, during the surgery, and post-surgery. So there are several recommendation items that can be implemented to improve patients' recovery, reduce the length of hospital stay, and also prevent complications. So in this journal, they had reviewed several RCT, prospective cohort with cohort group and meta-analysis, and then all these journals are being validated using consort checklist, which is consolidated standard of reporting trial, to assess the quality of these journals. And then the items or recommendations that were given from the journal were being graded, assessed and graded using the grading of recommendation assessment, development, and evaluation system. And then after all of this data collection of the recommendation, they were sent to a panel of experts, and this panel of experts will do write-ups of each recommendation, and then they will discuss with each other using the method called the 3-round web-based Delphi approach. So as a result, 8,368 potential studies, and then a total of 340 articles were included in it. So recommendation number 1, pre-operative counseling. So it is important to inform patient regarding the surgery, and then most journals recommended the usage of multimedia, as it can reduce the fear and anxiety and give a positive impact towards the patient. So there is a moderate level of evidence, and then weak recommendation for this item. Next is rehabilitation. Also, rehabilitation is important because avoiding sarcopenia, loss of muscle bulks, and loss of visceral adipose tissue before surgery may contribute to improve post-operative outcomes. So it is recommended a pre-rehabilitation program initiated 3 to 6 weeks before major surgery, and there are not much data on Whipple's surgery. However, this is based on major surgery such as colorectal surgery. So based on this, it has strong recommendation for pre-rehabilitation program before surgery. And pre-operative biliary drainage, it is not advisable to prophylactically drain the biliary system. Based on the RCTs journals that being analyzed, percutaneous transhepatic biliary drainage and endoscopic stenting has no difference in post-operative mortality. However, it does have increase in the rate of morbidity. And then, according to the recent meta-analysis, percutaneous biliary drainage seems to be inferior because it offers no clear advantage to other options in terms of post-operative complication, and it causes significant discomfort to patient. However, biliary drainage is needed if patient is grossly jaundiced, bilirubin is more than 15 milligram per deciliter, or if the patient is in cholangitis and having no adjuvant treatment at the moment. So due to these factors, preoperative biliary drainage is recommended. Prophylactic biliary drainage is not recommended. Okay, so preoperative smoking and alcohol consumption. So in a randomized control trial, absolute risk reduction in complication of 20 to 30% when smoking was stopped 4 to 8 weeks pre-operatively. Reduction of complication rate up to 20 to 30%. And then high alcohol consumption was associated with increased post-operative mortality. However, low to moderate alcohol consumption did not appear to have any increase in post-operative complications. So for nutrition before surgery, it is not advisable to start pre-operative nutrition in all patients because it render no benefits. However, for patients who had more than 50% weight loss or a BMI of 18.5, there is a positive outcome in reducing complication and improve patient well-being after surgery. So next is perioperative oral immunonutrition. So immunonutrition is a form of supplements, consists of arginine, glutamine, or free fatty acid that has been associated in several meta-analyses with decreased complication rate and reduced length of hospital stay in major surgeries. So however, most of the trials that being assessed in this item are industrial-based trials, and then there is also some biasness involved. However, the non-industrial funded trial did not display any positive impact post-surgery. However, based on the data provided, it does have some high-level evidence, but due to the biasness, it's not really a strong recommendation. Okay, pre-operative fasting and pre-operative treatment with carbohydrate. Okay, pre-operative fasting can be limited to 6 hours for solids and 2 hours for liquids in patients without risk factors. Pre-operative carbohydrate intake aims to improve metabolic condition to saturate liver glycogen immediately before surgery, and it helps to avoid the glycogen depletion state. Hence, there will be less episode of hyperglycemia post-surgery, reduce the insulin resistance rate after surgery. So pre-anesthetic medication. Okay, so for this, basically the aim is in pre-anesthesia is to reduce anxiety and to reduce the usage of opiates later post-surgery. So there are several medications that were being recommended, such as opioid-based medication, NSAIDs. Okay, so the aim for this is to cater these anxiolytics and analgesia based on the patient's need, and not to avoid giving anxiolytics in elderly patient as it post-operative cognitive dysfunction. Next, antithermatic prophylaxis. Pharmacological prophylaxis should be started 2 to 12 hours before surgery and need to be continued after discharge until 4 weeks. However, there is no much evidence for mechanical thromboprophylaxis, as it cannot be related to it cannot be it can relate to the episode of venous thromboembolism. So, but however, pharmacological thrombolytics, thrombotic prophylaxis can have benefits in avoiding venous thrombotic event complications. So for anti-microbial prophylaxis, okay, a single dose of antibiotics should be administered less than 60 minutes before skin incision, and repeated dose can be given according to the length of surgery. However, the usage of antibiotics post-surgery need to be catered according to the bile cultures that were taken during surgery. So there is no benefit in giving there's no benefit in continuing the antibiotics post-surgery without without referring to the bile cultures. So preparation, alcohol-based preparation are recommended, and then wound protector help to reduce the rate of surgical. So for epidural anesthesia, it is known. It is a known fact in many RCTs, in many journals, that thoracic epidural anesthesia for large open abdominal incision surgery is superior than to intravenous. However, thoracic epidural anesthesia has some systemic effect. It can cause urinary retention and motor block, and also hypotension. And then this episode of hypotension can occur despite normal intravascular volume. So it is recommended for a correctly placed catheter with an infusion of low concentration local anesthesia combined with low dose opiate to improve efficacy. Post-operative anesthesia, intravenous or oral, should be catered or tailored according to the patient's need. So it is advisable to follow each institutional expertise to give the recommended anesthesia for post-operative patient going through this procedure. This is a new thing, transderminous plain block. It is a wound catheter and transversus abdominis plain block. Okay, for this item, when it is being compared to epidural thoracic epidural anesthesia, there is no difference in the endpoint of pain score. However, with TAP block, there is reduced rate episode of hypotension and also urinary retention. Hence, this can be a good alternative compared to epidural, thoracic epidural, as it has low systemic effect. So post-operative nausea and vomiting prophylaxis. Okay, this is very important because post-operative nausea and vomiting can cause severe dehydration, electrolyte imbalance, wound deficiencies, and may complicate the surgery and cause of delay in hospital discharge. So all patients should receive post-op nausea and vomiting prophylaxis, and it should be catered to the types of patient. For example, patient with risk factors such as female, having non-smoking history of post-op nausea and vomiting before or motion sickness should be getting 2 or more antiemetic prophylaxis. Next is avoiding hypothermia. So clinical relevant hypothermia starts at 36 degrees. It is important to maintain normal temperature, as hypothermia can cause increased blood loss, cardiac arrhythmia, increased morbidity, increased mortality, and also increased rate of wound infection. Besides that, coagulation cascade can also be disrupted. Hence, it is recommended that patient should be at more than 36 at an optimum temperature, more than 36 degrees, and should be discharged from post-anesthesia care unit if temperature is above 36 degrees Celsius. Post-operative glycemic control. Okay. Okay. So for this item, it is important to keep the glycemic control at as normal as possible, because there are data that having episode of hyperglycemia patients are more susceptible to infection, and then the complications of hyperglycemia such as ketosis and so on. So it is important to maintain blood glucose level as normal as possible, as long as it doesn't compromise the patient's safety. Next, for nasogastric intubation. Routine nasogastric intubation brings discomfort to the patient as it is associated with increased respiratory complication. It is recommended that anti-tube should be removed before the end of anesthesia. Maintenance of nasogastric intubation after surgery does not improve outcome, and their routine use is not really warranted unless complications occur, such as delayed Glycemic, which I will tell later. So for fluid balance, okay, excessive perioperative fluid administration causes interstitial fluid shift, and then will cause bowel edema, and this will complicate the surgery as you can complicate the anastomosis if the bowel edema is present. So it is important to avoid excessive fluid administration, and then besides that, excessive fluid administration can also cause overload in patient, and then will cause other lung complication and increase length of hospital stay. So it is important in this era to practice targeted fluid therapy in order to improve patients' recovery post-op and reduce the complication. So in peri-anastomotic drainage, so for this item, there is conflicting evidence on no drain approach in pancreatic surgery. However, it is important to know that peri-anastomotic drainage is important to look for complication post-surgery, especially post-operative pancreatic fistula. But in this study, they suggest for early removal of drain if the drain amylase is less than 5,000 units. However, based on the evidence, selective no drain regimen is moderate, early removal is high, and then basically insertion of peri-anastomotic drainage is surgeon's preference lah. So it depends on the surgeons doing the surgery whether or not to insert the drain or to remove it early or at a later time. So somatostating analogs, okay, for this it cannot be recommended because trials results have not been validated yet. However, it is used to reduce pancreatic secretion, hence reduce the rate of pancreatic fistula formation. Most of the trial that is being reviewed do not specify the proportion of this fistula, so they do not really know what is the outcome of somatostatin analog. However, with somatostatin analog, it can be said that the incidence of post-op pancreatic fistula is reduced. So for urinary drainage, in patient with wound catheter or patient having thoracic epidural anesthesia, patient will have some form of urinary retention. However, this guideline, if the patient is able to pass urine post-surgery, it is recommended to remove indwelling catheter as early as possible, and patient should be allowed to pass urine by himself after the surgery. So next is delayed gastric emptying. Okay, so delayed gastric emptying after Whipple's procedure has an incidence of 15 to 35%. So this is the main usual cause for substantial increase in hospital cost and hospital stay, length of hospital stay. So it is important to recognize delayed gastric emptying. So far, there is a delayed gastric emptying definition by International Study Group of Pancreatic Surgery (ISGPS) define delayed gastric emptying based on three categories: category A, B, and C. And then these are mainly according to the length of nasogastric tube insertion, mainly on the duration of nasogastric tube insertion. So it is important to recognize this complication, as it is usually due to secondary cause, which post-pancreatic fistula formation or intra-abdominal sepsis. So if it's occur, we need to recognize the cause of delayed gastric emptying early to prevent patient to be having further complication and then increased length of hospital stay. Post-operative artificial nutrition. Okay, after surgery, patient should be allowed normal diet after surgery without restriction according to his tolerance. Then artificial nutrition should be considered as an individual approach according to the nutritional status. Enteral route is preferred rather than parenteral. Early and scheduled mobilization should be done before the surgery itself. Patient should be encouraged to walk, and then post-surgery, patient should have some form of mobilization, as it helps to increase to prevent venous thrombotic event. That's about all.